Stephan, it's great to see you and really nice to be here in Prague for the 2024 ISHLT annual meeting.
It's good to see you, Jim. Haven't seen you for a while, so welcome to Europe.
Thank you. So, Stephan, let's think back to our early days and ways in which you might think that your career was evolved, your mentors, some of the people that were really important to you.
Yes, well, I started in one of the most famous institutions in Germany, the Hanover Medical School, under Hans Borst, who was probably one of the very early international figures in our field. And at that institution, I started as a young surgeon, and we started as one of the early transplant programs at the time in Germany. And I think I finished my training over there, then moved on to Berlin, where we started the new German Heart Institute, which was one of the biggest in the country in the subsequent years. And I basically, completed my training. I started my early interest in science in there. And I also had my first presentations as ISHLT in 1984. Would you believe it?
And what was the state of transplantation in Germany when you first became actively involved?
I think we were just the second program. It was the first program was in Munich with Bruno Reichert, who was the pioneer in transplantation over there. And Hanover Medical School was actually the second one before it kicked off in other institutions such as Berlin and Hamburg, etc.
And what year would that have been?
This would have been 1985, yes.
So it's very interesting. It's not so dissimilar from my introduction, although my training was never in transplantation. My training was in congenital heart disease and adult cardiac surgery in Boston. And there was no transplantation program. It was early days. Recall during the 1970s when we were all learning about transplantation and how horrible the results were. And in the United States, in 1981, cyclosporin was first utilized at Stanford.
At Stanford, yeah.
And at that time, I had just joined the faculty at the University of Alabama in 1981. And at that time, there was a very close friend of mine named David McGiffin, who was a Fulbright scholar from Australia. And transplant programs were just beginning to be sort of reopened, but not very successfully. There was a program at UAB, and the mortality by the end of the first year was 60%. No cyclosporin was available. So when we heard the realization, the announcement that cyclosporin was going to be FDA approved in 1983, the surgeon who was doing those few transplants left UAB, Bob Karp, to become a chair at the University of Chicago. And so two young surgeons, one who had never really had a faculty position, David McGiffin, and myself, who was now 2 years out of my final training at age 35, began a heart transplant program with a resurrection of transplantation with cyclosporin in 1983. We had a number of patients on the waiting list because of the promise announcement, and then we began with no other surgeons around to support us, nobody else in the transplant field, and in fact there was no other center in the southeast part of the United States at that point. So even though transplantation was not really new, it was really a new era, which was really the same time that you got into it when cyclosporin became available. And then, of course, things exploded after that.
Yes. Yeah, I think we learned from centers like Stanford mainly with the introduction of cyclosporin. For me, as a young surgeon, I was looking at things like I couldn't believe that was possible, And those days there were also, it was all done fairly single-handedly. I remember I was still in training partially in general surgery, and during the daytime I did endomyocardial biopsies myself. So it was a very sort of simple structure in transplant programs, and the senior surgeon within our team was Roland Hetzer, who then moved on to Berlin, and I think that was the time when things really kicked off in terms of numbers, when everybody suddenly started to believe in heart transplantation with cyclosporin and the whole structure of programs.
You know, one of the people that had the greatest influence on me was Leonard Bailey. I never trained with Leonard Bailey, but I came to know him very well. I was interested in pediatric heart transplantation, and in 1984, the whole world was rocked with baby Faye.
Yes.
And you remember that the little baby had hypoplastic left heart syndrome.
Yes.
He had done a lot of work in baboons, but there had never been a xenotransplant performed successfully. And so when he performed that transplant, he never would again perform another xenotransplantation because the outcry from the public was just pronounced.
Absolutely.
But he ushered in the era of neonatal transplantation, and for that, I mean, he will be forever remembered.
Absolutely. He was, apart from his technical skills and his idea of innovation, he was an amazing human character.
Wasn't
he
he,
was
though?
absolutely fantastic.
Yeah, one of the kindest, most sincere individuals
Yes.
that I've ever met.
Absolutely.
And really that changed my world for sure in pediatric heart transplantation, because we all began to do infant cardiac transplantation in earnest,
Yeah.
particularly before hypoplastic left heart syndrome was a real surgical option
Yes.
for palliation.
Yes. So Jim, it's lovely to talk to you about the past. So if you were to look forward and a young surgical resident comes to you and said, Dr. Kirlin, what do you want me to do? I want to become as famous as you are. I want to become as successful, and I want to become as influential in the field as you are. What kind of recommendation would you give him?
Well, that's a tough one, because there really are so many opportunities now in the area of advanced heart and lung failure. I think, seriously speaking, it's find your mission. And whether it be in heart transplantation, devices, medical aspects of heart or lung failure, or one of the other subspecialties, if you can find an area where you can really make it your mission, and by that I mean not only providing superb patient care, but working to generate some new information, get involved with others, develop close colleagues that both from a professional standpoint and from a personal standpoint, that you can grow together, exchange ideas, care for patients together. And the ISHLT is really a wonderful place to really navigate that journey. One of the strengths of the society is both of us have really benefited from is the interactivity among disciplines. And you know, as we both remember, it started out as a surgical group interested in heart transplantation, but that evolved not only to lung transplantation, but the medical aspects, now all the other multidisciplinary areas. So I think for a young person, if they just get involved in areas of interest within the society, then join some of the committees, the upward mobility is greatly encouraged, and the opportunities are really spectacular.
How about this aspect of internationality? You know, there's always been a sort of issue and part of discussion to kind of connect U.S. and non-U.S. centers. And what would you recommend to someone who, let's say, works in a place, you know, somewhere in the world which is not particularly recognized, but wants to do something special in terms of the international connection? What do you recommend?
Well, that's one of the reasons I love the name of our society, International Society for Heart and Lung Transplantation, because for somebody from the United States, such as myself, there's a tremendous tendency to stay within the geographic confines of your country, to seek out other individuals just within your country. But ISHLT is very different, even though perhaps a majority of individual might be from North America. Mm-hmm. Everybody is concerned about the internationality. And so if you're from a small country or a less developed area of the world, you know, people from ISHLT greet you with open arms, personally, professionally, and in terms of your professional advancement. So I think it's really terrific. And the interest in diversity in this society is really pronounced and it's real. So that if you are from a country which is really beginning to engage in heart and lung transplantation or devices, or perhaps just in the middle of your journey, but you'd like better connectivity, ISHLT is there for you.
And maybe just another aspect of this, because a lot of centers outside of the US, they are struggling getting finances for research. I think ISHLT, I think this is under your leadership, has started to generate foundation for research projects, which are happening everywhere in the world, isn't it?
The ISHLT Foundation, per se, was formalized in 2021 and operationalized in 2022. And you're absolutely correct. One of the primary missions is to provide greater equity of research-funded opportunities outside of North America and really outside of Europe. So this is a major focus that we're all very proud of and is real, so that you'll notice that if you look at the awards that have been made, that an increasing number are for young investigators in non-North American countries. So Stephan, take us through some of your thoughts about where we go now. Transplantation, of course, is a very mature field, so is MCS. Young people are wondering, is there a role for me? Am I going to have a place? So where do you think we'll be going in the next, let's say, 10 years?
I think my perspective on transplantation and everything else around it has changed slightly over the last decade. I realize that doing transplantation is still a very elite therapy for only few patients, because the number of donors available, as everybody knows, is limited, very limited. And if we look at the number of patients in need, for those who are suffering from advanced heart failure, we are still struggling to find the appropriate number of donors. So over the last 2 decades, this area of mechanical circulatory support has become much more important to us in order to be able to treat more patients. You and I and others have, focused so much attention to the field of mechanical, especially durable devices for the future, and I think we have made huge progress. We now can demonstrate they have almost equivalent survival rates and outcomes, and I think it is important that we particularly push in this field and encourage companies to come up with better technology by using this technology in patients. And this is how I see my mission to expand in our society, to convince people that treating more patients is the essence. It's essential to realize how many thousands of patients are out there not having access to even assessment for their disease, and not talking about treatment. So in simple terms, I think the role of durable devices becomes much more relevant in the future, and we should put more research into this area, as we have done in the last 3 decades into transplantation.
Yeah, and maybe we can combine the two. I think one of the areas that I find most interesting is thinking about the 18, 20, or 30-year-old man or woman who says, I want to have grandchildren, I need to see my children grow up. And can you discuss with me a realistic possibility that I could live to be 50? So we all know that the median survival after transplantation for a child is probably 20 now. But for an adult, maybe 12-year median survival. Devices, right now, it's getting better and better, but it certainly wouldn't be more than 5 years or 6 years. But as we improve things, imagine a time in which we could have a collaborative conversation among experts like yourself and then your medical colleagues to devise a specific treatment plan for your patient that would begin almost certainly with a device, and then at a scheduled time that was dependent upon all of the research that had been done, combined with their desires for quality of life, and then transition them to heart transplantation.
Potentially,
of course, that would be of their choice. But the point is that the choice would be available to them. That if they wish to make that transition, that the allocation system would accommodate that. So I envision a day when there will be many individualized choices and plans for combinations, potentially even ultimately ending up in a total artificial heart many years down the road. But that would involve a number of devices, perhaps initial temporary, then durable devices, then eventually transplantation, and then maybe heart replacement, but in a way that would offer each individual patient a specific plan that would give them the greatest number of years of life with good quality.
And you asked me what I would expect for. I think one real important issue to me is also the potential of recovery. We've seen this as a spin-off of using devices, that there is a serious number of patients who can keep their own heart by treating them with devices for a period of time and then remove the device, and they can get on with their normal heart, with their own normal heart, without losing it. So I think this is another area which we have to put some effort in to understand more. How can we rescue a diseased heart and turn it into something which the patient can live on with?
Yeah, absolutely. Stephan, great to talk to you and catch up with you today, and please enjoy the rest of this fantastic meeting.
Well, you have been an inspiration to me. You asked me about my career. I wouldn't have been in this field without, stimulating my interest, and I'm most grateful to know you as a friend and colleague.
Thank you very much.